Hello and welcome to episode 33 of the LiveFitNow podcast. Thank you so much for joining me today. I hope you have had a good week. Now, today's episode sees me return to a subject from an earlier episode of the podcast, and the subject area is the menopause. So a couple of weeks ago, it was World Menopause Day, so I thought this was a perfect opportunity to revisit and continue our learning process of what the menopause is and all the things that we need to know as both men and women. So I cannot wait for you to hear today's conversation. My guest is a GP based in the Oxfordshire area. She has just started the Oxford Menopause and her name is Dr. Katie Barber. She is very passionate, very lovely, and shares so much wisdom in this episode. I can't wait for you to hear the conversation. Don't forget, you can get in touch with us. Just pop onto the show notes. Either contact myself or Katie directly. If you have any questions after the show, do not hesitate to get in touch. We would love to hear from you. So without further ado, here's the conversation. So I'd like to start by welcoming you to the LiveFitNow podcast, Dr. Katie Barber. So can you tell us a little more about your background and why you have chosen to specialise in women's health?
Gosh, that's a endless question, Vicky. Basically, I had a passion for women's health at university. I really enjoyed the sort of gynecology, women's health aspects. And then when I became a GP, it kind of just fell into place because I had a real affinity with listening to women, particularly about gynecological problems and day-to-day issues. So I did quite a lot of extra training as a GP trainee, did my diploma in the Royal College of Obstetricians Gynecologist. I did some sexual health and family planning training. And then I kind of found my niche. I just really enjoyed it. And I was working in the John Radcliffe Hospital with some urogynecology trainees, for doing some urogynecology training, looking at women with prolapse and women who've got bleeding problems, ovarian cysts, things like that. And I got approached by one of the menopause specialists up at the John Radcliffe, and who said, "Are you interested in doing some menopause work?" a couple of years ago, probably about 3-4 years ago now. And that sort of then led to me doing a diploma in menopause and becoming a menopause specialist. So, and then I started running the John Radcliffe Menopause Service about 18 months, 2 years ago. And since then, it's really taken off. So I've launched a private menopause service. I'm involved in providing a community gynae service in Oxfordshire, which is launching in the next couple of months. And really it's just getting bigger and bigger and bigger. And the more women I speak to, the more I find that there are women out there that need help. And the idea is I'm just trying to help as many of them as I can, really.
That's great. And why do you think it is a growing area? Do you think more people are asking for help? Do you think almost the more information that's being put out there, the more people want to know? Can you see any common themes as to why that might be?
Yeah, I think there's lots of different reasons. I think menopause particularly was a bit of a taboo subject and people didn't like to mention it to anybody. And even their GPs, it was something that you just didn't talk about. It's a natural process. You should just deal with it. Nobody should make a fuss. But actually, a lot of women are experiencing menopause very early, and we're living longer. So, we live maybe half our lives, some of us, in the menopause, and it has such an adverse effect on our normal day-to-day function, relationships, work, life, family, that I think women have just become a lot more empowered, and there's a really strong voice among women to try and be heard, and also ensure that they get the right support. I think celebrities have had fantastic input in publicising, particularly the menopause. People like Meg Matthews, Zoe Ball, Liz Earle particularly have been key in getting menopause out there and really advertising it on the television and the radio, and hopefully women feel a lot more empowered to ask for help. I'm still quite shocked by how many of my GP colleagues have not had sufficient training on the menopause, because that's still an area where a lot of GPs are really lacking, and it's not their own fault. It's just they can't know everything about everything. So I'm involved in quite a lot of teaching of trainees and GPs now to try and get it out there. But I think if women feel so much more empowered to go and get help, they'll ask the questions, they'll push for specialist input and help, and try and source it themselves, which is why, I think women are really quite proactive now, and I think that's changed over the last 20 years, but more so in the last 5-10 years, that the publicity about the menopause has been key. And it's really lovely to see that it's become a specialist area and people are recognising it and realising that women need help.
Yeah, no, I completely agree. And actually something I wanted to bring up was that point of almost, obviously there is undereducation from some GPs and nurses, and I've spoken to women before that probably don't get the detailed information and advice and support that they do need. How do you think women can best make sure they're actually going to people with enough information and knowledge to really advise them? Because I think if you're sent home thinking, oh, I can probably just get on with this, but perhaps it's not the best course of action, is there a way that these women can get to the right sorts of people?
Definitely. I mean, again, it's difficult for some women to know where to start, because if you Google menopause, you get all sorts of weird and wonderful information. There's a couple of really good websites I use. So the Women's Health Concern is a website which is produced by the British Menopause Society, and I trained and did all my diploma with the British Menopause Society, and all the information on their website is evidence-based, it's medically approved, it's written by menopause specialists. They have a really lovely fact sheet section which sort of gives information about different aspects of menopause, HRT, non-hormonal therapies. So for a lot of women, that might be a starter for 10 to say, actually, I've got a lot of these symptoms, let me go and get help. A lot of private specialists like myself have information on their websites about the symptoms of the menopause and, you know, when to seek help from your GP. And I think actually if women go to their GPs now, I mean, I'm a GP, so I don't mind if someone comes in with a leaflet and says, I think I've got this going on, let's talk about it. I'm like, fine, great, you've got some information, you've clearly thought about this. And I think it was interesting, I was on a webinar today with a couple of menopause specialists across the world. One was in Switzerland and one was in Italy. And the thing that was really interesting about the lady in Switzerland is she said she gets women to write a wish list, a bit like a Father Christmas list. You know, what things do you want me to solve in the order that you want me to solve them? Because she said women come in now very much like, you know, I don't just want my hot flushes fixed. I want my libido improved. I want my skin and hair to feel better. I want my dry vagina to feel better. And they list their sort of order of preference. Whereas she said years ago, it would have been like, oh, I don't know whether I should mention any of these other things, but actually, can you just fix my sweats? And it's really interesting how women are now getting the information, thinking this is linked with the menopause, I need to get help with this. So yeah, the Women's Health Concern is really good. For young women who've had an early menopause, there's a fantastic network called the Daisy Network, which is specifically designed for women who are young, under 40 predominantly, who've had either a natural menopause or a surgically induced menopause, they've had their ovaries removed. And it's got a forum as well for young women to sort of get in touch with each other so they don't feel alone in their early menopause. But I mean, Google has a lot to answer for, doesn't it? There's just so much information out there, but these are some really good websites I'd recommend.
No, that's great. And perhaps this is a good opportunity to ask you to summarize what exactly the menopause is, and is the menopause the same if you do go into it younger or older at the sort of average age?
So if you talk about normal menopause, we say that after the age of 45, menopause is defined as your periods stopping. So if you have 12 months of no periods, you're defined as postmenopausal. And that means your ovaries have stopped producing eggs and therefore the estrogen levels plummet and your brain starts to send signals more desperately to the ovaries saying, come on, produce some eggs. And that causes high levels of a hormone called FSH, which is produced in the pituitary gland in the brain. And that FSH rise, that because your brain's desperately trying to stimulate your ovaries, is what causes all those horrible flushes and sweats particularly. So that's sort of natural menopause, a decline in ovarian function that happens after 45. If it happens before 45, between 40 and 45 is slightly early, and under 40 it's what we call premature ovarian insufficiency. In other words, your ovaries are not supposed to stop working that early. On the whole, that's where menopause happens when there's no obvious underlying reason. But for a lot of women, menopause happens surgically or chemically induced. So I meet a lot of women who've had their ovaries and wombs removed for cancer, for endometriosis, for pelvic pain, various things, heavy bleeding. And clearly, if you take the ovaries out at a very young age or at any age, you're going to plunge yourself into a surgical menopause, which is where the brain still switches on to try and stimulate them, but there's nothing there. It's not a natural decline. It's not a gradual introduction of menopause. It's one day they're there, the next day they're not. And some early menopause in women under 40 has an obvious cause. So I meet women who've got genetic reasons for their ovaries to stop working, or they've had a cancer that's had their ovaries removed, and even young women. So this is when I really, I'm passionate about making sure these women are well looked after. These sort of teenagers that have had chemotherapy for cancer as a child, so leukemia, lymphoma, sarcomas, and they're rendered essentially infertile and menopausal at very young ages. That's really important that they get the right advice, because it has adverse effects on their bone health, their brain health, their cardiovascular risk, emotional issues, etc., etc. I could go on forever, but yeah, that's sort of menopause in a nutshell. Most of the time it's a natural cessation of ovarian function, but for some women it's an early or surgically or chemically induced issue.
That's fantastic. Thank you for describing that. And this leads me nicely on to my next questions. What are the most common symptoms that people will start to experience?
The commonest ones that women want help with are usually flushes and sweats. That's the one that we all remember. Bizarrely, it's probably the easiest thing to fix as a menopause specialist. You can get rid of flushes and sweats quite easily. But my opening thing to a patient that comes in and says, I'm not really sure this is attributable to menopause, is any symptom a woman ever mentions to you is probably menopause driven. So the common things I see are flushes and sweats, but more frequently these days, it's fatigue, it's muscle aches, it's joint pains, it's dry skin, dry hair, low libido, changes in mood, emotional lability. So feeling happy one minute and sad, and there's no trigger for that. Relationship issues, dry vagina, generally losing their va-va-voom and zest for life and enjoyment of life, difficulties concentrating, brain fog, inability to sort of process information as quickly as they normally can. So when these women come in and they've had really high-flying jobs and they say, I've had to quit my job because I just can't stand up in meetings anymore, I can't find the right words. So all of those symptoms. But to be honest, there's loads more. Skin rashes, funny itchy skin, changes in sort of general normal day-to-day function and ability to process information. Anything can be menopause.
Wow, quite a list.
I've got this to look forward to.
Yeah, well, quite as far. I want to empower myself with as much knowledge as possible. And what should we do if we get any of these symptoms, even if they're not necessarily having a massive impact on our lives? Is that a good time to go and get a little bit more advice, or should we be waiting for, I guess, something we don't want to have to put up with anymore?
Yeah, I mean, I think that the one thing to say is it's never too early for us to ask for help. If you've got symptoms, particularly if you're under 45, there are huge advantages to getting the correct advice and having hormonal treatment if it's appropriate for you to take it. So women who have an early menopause should be encouraged to take hormonal therapy up until the natural age of menopause, which is around 51, 52, because there's an adverse effect on their bone density, cardiovascular disease risk, brain health, etc. If you're over 45, there's no necessity to get treatment, but there's no point in waiting to see if it passes. If it's in affecting you and affecting your quality of life, there's things out there that can improve your symptoms. And it doesn't necessarily mean HRT in everybody. It might mean other things. And the key thing I always say to women is, whatever I prescribe or advise you, the key things for you to do are to stop smoking, reduce your alcohol, undertake regular exercise, maintain a healthy body mass index, try and have some quality time and work-life balance if you can, because that gets harder as we get older when we're having to deal with the menopause. So if you can look at all those things, ask your employer for some support. Employers are becoming very, very good at addressing the menopause and recognizing it impacts on women's ability to work efficiently. So never ever too late to ask for help. And a lot of the time it might just be actually, what can I do to make this better myself? Or do I need some support? Are things bad enough that I want to rectify it?
That's wonderful. You literally just answered my next question. I love it.
Good.
That's reassuring to know as well, because obviously it is something that all women are going to go through at some point. And I think people really hate the idea of losing control. And so as much as it's something that has to happen, it doesn't mean there aren't things that we as individuals can do to try and improve the situation. And if we get to the point where we can't help ourselves anymore, there are people like yourselves that we can come and see and get some more help and support from.
Definitely. I think the thing to say as well about lifestyle is, we know that flushes are worsened by caffeine and alcohol. So these are simple things you can do to improve symptoms. And, the other thing is bone density is really important to maintain. That starts to decline when we hit the menopause. So do some weight bearing exercise. I always say to women, you don't have to be a member of a gym, just something that gets you slightly out of puff, 30 minutes, 5 times a week, walking around the block briskly, or doing some weights in the garden. Anything like that is great because it's going to improve your bone health and reduce that risk of osteoporosis, plus helps with weight loss and maintaining healthy body mass index, etc. And yeah, just really trying to address things yourself. But I think women are asking for help a lot more. The difficulty with the NHS specialist services is often they're quite restricted about who we can see. It has to be certain niche groups that are really needing specialist advice. But there are more and more menopause specialists like me operating across the UK, particularly in private settings. And most GP practices now have a couple of GPs normally who have a women's health slant. I teach across Bucks, Berks and Oxfordshire and beyond, educating medical students, junior doctors, GPs, and doing a conference in a couple of weeks actually, where we do an annual update about changes in guidance about breast cancer risk and things like that. So there's normally somebody, even if your usual GP that you see isn't really hot on menopause, they can normally ask someone else. And I'm constantly educating my colleagues at work.
That's fantastic. Very promising for the future. The fact that more and more people are going to know more. A question between the NHS and the private: are there treatments that we can only get if we go to a private doctor compared to the NHS?
The simple answer to that is yes. But the equivalents are available on the NHS. So in my private clinic, there's only one treatment that I offer privately that is just not available on the NHS. It's not licensed on the NHS, and that's a private testosterone therapy. It's marketed for women specifically. So it comes in a package that's designed to dispense the right dose for a woman, but the NHS hasn't licensed it. But we use an equivalent product that dispenses a similar amount that's used for men, but we use it for a woman. So the bizarre thing is that, this is a female product that's available, but yet we aren't licensing it. We're using a male product in women, but it does exactly the same thing. All the other options I use for hormonal therapy and non-hormonal therapy are all evidence-based, MHRA regulated, licensed on the NHS. These are widely available products. There's a few newer products coming through, certain treatments for vaginal atrophy and soreness, and they are currently often sort of county limited. So in certain areas of the country, your CCG, the prescribing authority, won't let you prescribe them, but they are licensed on the NHS, so some areas can get them. So it's a bit of a postcode lottery on some products, but on the whole, I ran a menopause clinic a couple of weekends ago, and every treatment I prescribe, I know I can prescribe in general practice on the NHS, so patients can get it from their GP if they want to.
Yeah, that's great. Thank you for clearing that up. And with HRT, does that particularly address certain symptoms that you might get, or does that actually across the board hit lots of the symptoms you might be getting?
On the whole, it pretty much fixes most of the symptoms. It's the gold standard for treatment because we know it's so effective if you get it right and prescribe the right treatment for the individual person. The only things HRT on its own, so we're talking about estrogen and progesterone, that doesn't improve the libido aspects and sometimes the mood and cognition and slow memory and fatigue and muscle strength. That's where testosterone really comes in And it's great that it's been licensed by NICE in 2015, because we can use that alongside. And women often find the majority of their symptoms get better once their HRT is sorted, but then they need a little bit of testosterone. Women who've had their ovaries removed, significantly affected by low testosterone levels, because we produce about 50% of our testosterone in our ovaries. And so when your ovaries are removed, then you really find that level plummets. Whereas women who have a natural menopause and their ovaries are just declining naturally, it's often less pronounced. So particularly for young women who've had oophorectomy, I do find I need to give testosterone as well as estrogen a lot of the time, particularly for those more subtle symptoms. And the improvements you get are quite subtle as well. But yeah, on the whole, HRT is a pretty wonder drug.
Yes. Perhaps could you give a brief summary of what exactly HRT is?
Sure. So most HRT products are derived from plant-based estrogen. So the real hormone we need after we've gone through the menopause is estrogen. That's what our ovaries have stopped producing. If you've got a uterus, you have to have a combination of estrogen and progesterone, because otherwise the estrogen can cause some abnormalities in the womb if you give it on its own. So if you've got a uterus, you have to have both hormones, but it's the estrogen that's really giving you the benefit. And most of the products that we see on the market now, the estrogens come from plants like soy or yams. And lots of people talk about bioidentical HRT, and these are sort of more bespoke treatments that are made by some clinics that aren't licensed or regulated in any way, shape or form. So that's not the kind of therapy I use. I tend to use more sort of body identical HRT. So these are, it's like the yam extract, but it's no different to what a normal ovulating woman would be producing. And we often combine that with some progesterone if you've got a uterus. If you don't have a uterus, on the whole, you don't usually need the progesterone element. It's just the estrogen bit. So it's really the three hormones. Estrogen and progesterone are the main issues with HRT, and then adding on some testosterone alongside, and not forgetting that HRT isn't just about pills, potions, patches, gels. It's all about vaginal treatments as well. So creams and pessaries to treat vaginal symptoms, because sometimes just HRT on its own isn't enough to address those.
That's great. Thank you for that summary. And I was asked today by one of my clients actually, and she said, is there a test that could be done, a blood test or any other kind of test that it might be, to confirm whether you are or not going through the menopause, or is it purely based just on symptoms?
There is a test, but it's not helpful in the majority of women. So in women over 45, there's no need to test. And I get so frustrated because I get even my GP colleagues checking FSH, the hormone level that goes up when you hit menopause. This lady can't be menopausal. Her FSH is normal and she's 51 and got terrible flushes. She's menopausal, just treat her. Because FSH can be normal. If you've still got some ovulatory function, you might just capture it at the time when it's normal. It can be suppressed in women who are using hormonal contraceptives. So you then check it and it's low and you think, oh, this isn't menopause, but actually it is. It's just that their contraception's suppressing it. The only time where it's really essential to use FSH testing is in women under 40, because you want to achieve a diagnosis of this premature ovarian insufficiency. And the guidance is we should be checking women under 40 twice, 2 readings 6 weeks apart. But I sometimes check it in women between 40 and 45 if I'm not sure, is this menopause, is there something else going on that's causing their symptoms? Once they're 45, there's no need to check. And a lot of women are worried about whether it changes, if it's how high it is, does that tell me where I am in the menopause? And unfortunately, that doesn't happen either. You can't predict fertility or future ovarian failure. You can't say when your menopause is going to be as a result of your blood test. So your short answer is yes, there is a test, but we wouldn't advocate it in women over 45 because it's unreliable and it stops you getting treatment a lot of the time.
Of course. Are there any common things that are often confused between having the menopause or something else? Are there ones that you perhaps, if you get the symptoms but you weren't going to go to the doctor, it's best to, just in case it's something else?
Yeah, there's a few weird and wonderful conditions that can cause menopausal symptoms. So thyroid disease, under or overactive thyroid disease can cause similar problems to the menopause, particularly underactive thyroid, sort of sluggishness, fatigue, weight gain, flushes, those kind of things. There's also a condition, it's more rare though, where you have a little tumour in the brain that can secrete prolactin, which is the hormone we produce when we're breastfeeding, and that can often mimic menopause, because women often have their periods stop because it's like they're in a breastfeeding state, and they can often get quite hot and sweaty and feel quite unwell. So definitely, you know, there are lots of other things that you need to consider. The thing that I see most that's incorrectly diagnosed is the mood issues with menopause, and women being given antidepressants when actually they should have had HRT, because their mood symptoms were not mood driven, they were more hormonally driven. But there's a couple of other weird and wonderful autoimmune conditions that can cause your ovaries to stop working normally and also mimic the menopause. So I would say if you've got symptoms and you're not sure what's going on, it's always worth asking for help and getting to see your GP.
That's great. And what is the shortest and longest length that menopause can go on for?
Well, the shortest menopause is probably a few days. The longest menopause goes on till the day you die. There was a really useful lecture last year at the British Menopause Society conference by a fantastic professor who was really extolling the virtues of HRT. And one of the delegates at the end said, you've really said that HRT is something to be celebrated and very little risk associated. When should women stop? You know, when should we say enough is enough? And he lowered his glasses to the end of his nose and he says, when women are in a coffin, it's probably soon enough. And his view was that, you know, if you feel well with your HRT, it's giving you quality of life. There's no arbitrary time limit. And actually that's been replicated, that view, in some recent studies where we've said, look, there is no arbitrary time limit. You don't get to 60 and say to women, sorry, that's it now, you should be done, finish. It's a case of let's reevaluate you on a case-by-case basis. So for some women, I mean, usually it's a few years and they start to feel as though they're getting on okay. And if they have taken treatment, they can wean it off. But for some women, it's life-changing and persistent and never-ending. So I have a few ladies in my clinic between 70 and 90 that are still taking HRT. And if I look as good as they do at their age, then I'm on it too.
Wonderful. And are there any side effects to worry about? I know historically there have been some negative press with HRT, and I've spoken to many women who are cautious to go on it for that reason. So what are the most common side effects and how common are they?
Yeah, I mean, the commonest side effects from treatment are going to be from which hormone you're using. So, or is it too much or too little? So bleeding problems can be an issue, particularly if you haven't got the right dose right, or you've not got the right progestogen going in, or women have got other things going on like fibroids or endometriosis. That can often be easily rectified by just adjusting the progestogen element of their HRT or changing the estrogen dose. If you give too much estrogen to a woman too quickly, you get intensely sore breasts, nausea, bloating and headaches. So a lot of the time when women come to me in clinics, I just couldn't tolerate HRT, this is what happened. I was just like, well, let's try a really low dose and gradually build up, and then you probably won't have those side effects. So they're the commonest ones, bleeding and side effects from the medication. Unfortunately, progestogen, which you have to have if you have a uterus, is that delightful hormone we get premenstrually that makes us feel pretty yuck, sluggish, moody, bloated, miserable. So you can imagine if you're having to take that because you've got to have it because you've got a uterus, that's usually the issue that I find is most tricky with women. But there are ways of overcoming it. There's some more natural progesterones we use at the moment. And interestingly, they're the ones that are associated with little or no increased risk of breast cancer in women using them for up to 5 years. So going on from the side effects, the other thing women worry about is the scaremongering among the headlines about breast cancer risk. There was a paper produced today, funnily enough, it was a sort of a case control study that was released to say about the up-to-date breast cancer risk. And we do know that the articles previously produced that frightened women just didn't reflect the data appropriately. There are certain combinations of estrogen, undoubtedly, with progestogen that have a higher breast cancer risk than others. I personally use a lot of body identical HRT, which has been shown not to increase breast cancer risk for women using that for up to 5 years. But the studies have really shown that it's not just the HRT, it's how long you use it for. And, you know, prolonged use is going to increase your risk. It's lots of other risk factors. So we know that obesity, going back to the lifestyle, obesity, smoking, alcohol, these all increase your risk of breast cancer. Obesity particularly, way more than HRT does. And it's about balancing those risks. So I'll often sit with patients and say, look, let's have a look at your baseline risk factors for breast cancer. Now let's talk about HRT. It's nowhere near as risky as what else is going on in your life at the moment. And obviously we've got to be mindful of women who've got a hereditary tendency to get breast cancer and any treatment they might be on. So the breast cancer risk is the big negative with HRT. The side effects are minimal and most women tolerate it extremely well.
That's fantastic. And I guess it's the balancing of risk factors to quality of life as well. Because your quality of life, if you're experiencing several, particularly the severe symptoms, is going to be far more detrimental than the percentage of risk that you're going to have from taking certain medications.
Absolutely. And I think the one thing I always say to women is that one of the biggest killers of women in Europe is cardiovascular disease. And HRT reduces that risk by up to 50% in women using it on and around 10 years of the onset of menopause symptoms. So that's the more risky thing not to protect yourself against sort of longer term. And HRT has such fantastic benefits for that, reduces the risk of diabetes, dementia, osteoporosis. I mean, the risk of having a fatal hip fracture as you get older is significant. So these are all things you're being protected against. So let's talk about the real benefits of HRT. And yes, there is a breast cancer risk for some women. And yes, it's important that we're mindful of side effects, but there are fantastic benefits to these treatments that often women aren't told about.
That's excellent. They've heard it here. So are there any common myths linked to the menopause, or indeed any female health, if you'd like to bring it in, that you would like to debunk?
Oh gosh, yeah. There's the bioidentical thing about the menopause, and women often come to me with these preconceived ideas of that I'm going to bespoke their HRT and give them lozenges and creams, and that is not licensed, not regulated, not evidence-based, not safe in some circumstances. So that's the first thing to say is it's not better than anything we can prescribe that's regulated and licensed. What I prescribe is safe. I can back it up with data that shows its efficacy and its safety. So that's the first one is, bioidenticals are not always what they're made out to be. The other myth about HRT is that the breast cancer risk, it's that headline of breast cancer, you'll get breast cancer if you have HRT. For a lot of women, that's not the case. If they have got breast cancer and they used HRT, it's not necessarily because they took HRT, lots of other risk factors. The other thing about the menopause that's an interesting one to debunk is women think that HRT is a contraceptive, and it's not. Unless you use a coil as part of your HRT tablets or patches are not going to stop you getting pregnant. And despite our best intentions in the menopause clinic, we've had a few unplanned pregnancies because women have just assumed that their HRT is a contraceptive. Some of them are actually delighted, even if they're older ladies, that are unplanned pregnancies. But yeah, that's a really common one. And even some GPs think HRT is a contraceptive, and it's not. So that's that one. The other one that we've sort of alluded to already is that you can do blood tests to tell how far you are through the menopause, and you just can't, unfortunately. The other one that's quite funny, really, from some women's perspective, and I have some delightful patients in my clinic who tell me intimate details of what goes on at home, and some women will say to me, "You're going to give me testosterone? Am I going to turn into a man now?" And it's no, I promise you're not going to. We monitor it very carefully. It's really low doses. And a lot of the time, the changes you get are very subtle. I mean, some women will say, my libido is rock bottom, and am I going to feel like I'm 21 again? And I said, well, it's unlikely. You're not going to be running around after your partner in the bedroom as you would have done when you were young, but it should hopefully give you a little bit of an improvement. And for a lot of women, it's just that slight subtle increase that really makes life a lot better for them.
Oh, that's excellent. Thank you. I'd like to actually go back to women that experience the menopause younger. Is it a lot harder for people to realize that is what they're experiencing? Like, are a lot of young women potentially suffering at home with certain symptoms, but it's not even popping into their head that could be an option? Are there any telltale signs? Do you think there are any ways that we can hopefully educate women younger to realise this is what's going on?
Yeah, I mean, I'm really glad you've highlighted that, Vicky, because particularly World Menopause Day last week, that was one of the topical things they were mentioning about premature ovarian insufficiency. And a lot of the women that come to me with this diagnosis are found because they've been investigated for fertility reasons. You know, they haven't managed to conceive, and then they found that they've actually got POI. Really, if you're under 45 and you've got any symptoms of the menopause, you should really be asking for help, twigging that this is not quite right, and go and get some help, particularly if you're having long gaps in between your periods, you're getting hot flushes and sweats, you're feeling more emotional, you're tired, fatigued, because these are the women that we really must ensure are given the correct treatment and advice to stop long-term risks from having an early menopause. But there are lots and lots of women out there who just say, oh, mum had an early menopause, I'm having an early menopause, it's just genetic. But yeah, really, really important. Under 40, absolutely, definitely get your GP to start the ball rolling with some investigations. This is all stuff your GP can do. Between 40, 45, ask for help. A lot of the patients in my clinic are these difficult early menopause patients who maybe are a little bit unusual and the GPs don't know what to do. And I'll often do some genetic testing. I'll do some further evaluation and try and find out why they've had an early menopause. So yeah, if you think you're going through a menopause earlier than you should be asking for help.
So I'm guessing the first recommendation is to get in contact with your GP. But if you're coming across perhaps the less open-minded GPs, shall we say, is the next best place to start looking on some of those websites you mentioned earlier, or trying to find a local private clinic like yourself?
Absolutely. I mean, the British Menopause Society has on their website and the Women's Health Concern website a Find a Specialist section, and that lists every registered NHS and private service in the UK that has affiliation with the British Menopause Society. As a British Menopause Society recognised menopause specialist, I'm listed on there in an NHS clinic capacity and a private clinic capacity. So the specialists on that website are all accredited. We've had training, we know what we're talking about. We use evidence-based medicine, we're not just setting up on our own. And that's a really good starting point for some women. Plus, those websites contain all the information to really arm women with the information they need to go and challenge their GP if they're not getting the answers they want. See another GP. You know, most GP practices have got lots of different doctors in there. And if you happen to find one that doesn't really know very much, but someone else in the practice does, then that's your key to try and get some support. But I take self-referrals. I don't insist on a GP referral. You can just ring and email my service and get yourself booked in. And in fact, that's all the referrals we've had so far, of just women finding me online and then saying, please, can I come and see you, please?
Are there any reasons that you wouldn't prescribe HRT if a woman is in a particular circumstance that you would say no, essentially?
Yes, there are. So we really don't advocate women having HRT if they've got a history of breast cancer, because the majority of breast cancers are estrogen responsive, so they're stimulated by estrogen. So a question I'll often be asked is, but I had breast cancer 5 years ago and I'm told it's gone. Why won't you give me HRT? Now, when you've had treatment for breast cancer, the idea is that you eliminate as many abnormal cells as you can, often with chemotherapy or radiotherapy after any surgery. There's always that small risk that a stray cell is left behind, and the majority of women, our immune systems just keep that stray cell at bay and it doesn't ever cause us a problem. But if you then feed that stray cell with estrogen, that's when the risk of recurrence occurs. So it's really not a good idea for women with breast cancer to have HRT. And often women will say, but my tumour wasn't estrogen receptor positive. And there's still some evidence that you can have a secondary tumour that then is estrogen driven if you've had that first history. So certainly breast cancer, not a good idea. The other tumours that are very hormonally driven are uterine, endometrial tumours, tumours of the womb, and they are estrogen driven as well. Women with very, very early womb cancers, so what we call grade 1A, it's tiny, tiny abnormalities, they can still have HRT in the majority. There's the odd exception, but on the whole, they're okay. But more aggressive uterine tumours, again, for the same reason as recurrence risk in breast cancer, we would say, no, that's not ideal. But even women with ovarian cancer, vulval, vaginal cancers, bowel cancers, they can have HRT. We would never start HRT in a woman who had abnormal bleeding that hadn't been investigated, or a breast lump that hadn't yet been investigated. Obviously, if you tell me you're pregnant, I'm not going to give you HRT. Having said that, common question is, I've got premature ovarian insufficiency, my period stopped 4 years ago, and I'm going for fertility treatment, so I can't have HRT. No, you should have HRT until you have your fertility treatment. And often the fertility team will give you far greater hormone doses than HRT gives you. So being pregnant is a contraindication, but not pursuing fertility treatment if you've had an early menopause. There's a few other weird and wonderful conditions. So autoimmune things that maybe make the choice of HRT slightly more difficult. If you've had a recent heart attack or a stroke or a recent onset blood clot in the leg or lung, you should wait till everything's stabilized. So often we say wait 12 months after a heart attack or stroke, optimize your risk factors for further events. So stop smoking, minimize alcohol, weight, cholesterol, blood pressure, all the other things. And then it would be safe to either restart or initiate HRT. But a lot of women will come to me because they've been told they can't ever have HRT because they've had a DVT, a blood clot in their leg. But they just can't have a tablet form of estrogen. They have to have it in a patch or a gel because then it doesn't increase their stroke or thrombosis risk. So yeah, there are a few situations, but there's not that many. There's a lot of women out there who could benefit from HRT.
So a story that I have been shared, a lady went to see their specialist nurse and they were told that they couldn't go on it because of them being slightly overweight. Is that... I'm really glad you gave that response because I thought that might be the case. I know you can't give individual, obviously, response, but I was skeptical to think that that would necessarily be true.
It's frustrating, this, because you think, oh, these poor women out there that are just being declined these treatments that could make them feel so much better. So if you have a body mass index of over 30, so technically that's in the obese category, you shouldn't really nhưng oral estrogen tablets because that significantly increases your thrombosis risk, which is already increased if you're overweight or obese. But you can have a patch, you can have a gel. I have women in the clinic with BMIs of 40, 50. They can still have HRT. I just wouldn't give them a tablet because that would be not advisable with their higher stroke and thrombosis risk. But yeah, body mass index under 30, pretty much anything is okay orally. Over 30, gels and patch forms of estrogen. It's the estrogen component that's giving you the majority of that thrombosis risk. There are some of the progestogen elements do increase your thrombosis risk as well. So again, with overweight women or obese women, I tend to steer clear of the more thrombotic progestogens, we call them. But there's lots of other choices. And so, yeah, the world is your oyster. There's loads of options. Don't feel because you're overweight you can't have HRT, you can.
Well, that's wonderful and reassuring, and I will certainly pass on your details to
Good. Yes, do.
What's my next question? What do you think the biggest issue that we face in regards to menopause in the future?
Oh, gosh, that's a good question. If you'd asked me that a year ago, I'd have said physically getting hold of HRT. It's the availability has been a nightmare. I think the whole kind of supply chain of HRT, just at a point when women were really getting empowered to get to HRT and get advice, it just didn't coincide well. So you had these huge supply problems, and theoretically that may still be an issue in the future. I think one of the bigger issues is ensuring the correct treatment for women, because women are a huge part of the UK workforce. We are working longer. And I think I probably end up being about 75 by the time I'm allowed to retire. So, we're going to be working 20, 30, 40 years, some of us, in our menopause. And we've got to be productive. We're not living in the olden days where the women stay at home and the men go to work. We have much more joint sharing of responsibilities at home, and women are working, and it's not about just raising children anymore, which is a fairly archaic view. So it's so important that we look at this aspect of menopause and its impact on the economy and women's normal day-to-day function, and ensure that that's optimized as much as possible, because we are a fantastic source of wealth and income for the UK. We need to be able to do that. So that's probably the biggest challenge.
Yeah, absolutely. And how do you think we can educate people? I mean, this, men and women, we all need to have a broader knowledge, I think, that this is going to happen to us all at some point, what the symptoms might be, the fact that it's going to be different for everybody, but we all need to be aware of what's going on so we can prepare for it, support each other through it, understand what we need from the other through it.
So it's really interesting. I got asked a similar question on the radio last week about this, and my two daughters are 6 and 9, and so the older one's starting to do the PSHE. I can never remember the way round. A PSHE, I think it's called, and they'll talk about puberty and periods, but I don't think they cover the menopause. And actually, it's really important that we start children young, recognizing the different stages in the life cycle. It's not all about contraception and pregnancy and periods. It's what happens at the other end, because for a lot of these young women, it doesn't happen at 45 plus, it happens much earlier. And they need to know that that is going to happen to them at whatever point it does. So bringing that education into the classroom is really vital. I mean, my children, I think, probably get bored of me talking about the menopause because they know exactly what's going on, even at such a young age. My husband certainly knows what to get me if I don't recognise it myself, but one would hope I will. But I think that's the starting point. And then, incorporating it into the GCSE biology syllabus, science syllabus for youngsters to understand what's going on. And more through the sort of the medical side of things is I'm very passionate about trying to train medical students. So when I was a medical student, the menopause, I can't even remember if there was a separate lecture, but I now do a lecture with every gynecology group that come through the Oxford Medical School. I do that every 8 weeks to try and get them sort of really familiar with what's going on at menopause. And the same applies to post-grad training. Get the GP trainees, get the O&G speciality trainees coming through and really knowing what they're talking about. They say, if you're a gynecologist and you're going to do a hysterectomy, oophorectomy on a woman, you need to know what to recommend to that woman about HRT, but so many of them just don't have the training. So yes, start at the beginning and really expand it through. But I would love to see menopause on the syllabus in schools. That would just make my day.
It just makes so much more sense, doesn't it? The more kids understand at a young age, it just becomes the norm. And talking even slightly more broadly just about women's health, do you think there's still just a feeling of taboo around all of the things that women go through? And also obviously bearing in mind that men are going through their own changes throughout their lives. Do you think, how are we going to hit the people that are already past school? So hopefully, fingers crossed, they start to educate the kids, but how are we going to try and integrate these conversations to become more normal in our societies? Because we can't let these decades of people just bumble on and almost feel embarrassed by it all from both sides, because it really is, it's so natural, but yet not quite accepted yet. But do you think this is just going to take time?
I think it is going to take time, but I think there's lots of different ways of improving women talking about these problems. The first is from the medical aspect, is just ask the question. I can remember so many times those patients with the hand on the door about to leave the consulting room, and they've come in and they've asked you about something that's pretty simple, like a medication review, and then they really want to talk about vaginal dryness or their prolapse or their incontinence, and they're just about to put their hand on the door. Do you know anything about incontinence or prolapse, doctor? Well, yeah, come and have a seat. Let's talk all about it. And the more you make women feel this is a completely okay thing to talk about, the better. So, the more publicity we can do, the more things like this, Vicky, that we can really reach women online. I mean, thank goodness we've got the internet these days, because women can look at YouTube and podcasts and webinars and you name it. And actually, COVID in a way has done us a favor with a lot of this, because women are actively using IT for work and then exploring all these other aspects. So that's fantastic if they can learn online about the things they need to do. But it's also, you know, as a GP, just make sure you ask that question. Are you all right? Is there anything else going on? A lot of the time, when I get women in for either contraceptive or HRT reviews, I'll do the simple things like bleeding and flushes and sweats, but then I'll say, is everything okay? Is your vagina happy? Is it dry? Is it sore? Is sex painful? And then all of a sudden they'll sort of look at me sometimes and say, gosh, no one's ever asked me that before. Actually, it's a real problem. You know, my husband and I relationship is really falling apart because it's just not comfortable. Okay, well, let's have a chat about that. Can we examine you? Let's see what's going on. I think the cohort of women 60 plus are still a little bit embarrassed about talking about it, and particularly with things like incontinence, pelvic floor issues, prolapse. It's often you opening that conversation, or them saying, how can I get incontinence pads, doctor? And then you have to explore it a bit more. But yeah, internet, amazing resource.
Yeah, I mean, I'm also thinking that some of those issues are very common issues that are being experienced from women actually from quite a young age, often post giving birth. I am
absolutely
from other people's stories rather than my own to fully understand. But I appreciate that. I think a lot of things, again, perhaps aren't discussed with some of the realities, what actually carrying a baby, giving birth, and after that, what it actually does to our bodies. I think sometimes we just think about wanting a baby, having a baby, suddenly it's there, and then we move on. But actually, there's a lot of things happening to our bodies that perhaps we're not expecting and perhaps don't want to talk about.
Absolutely. I mean, the core question I ask at the postnatal check at 6 weeks with women, once I've talked about how they're getting on and how life is and mood and usual things, is, you know, how is your bladder control? How are you working? Is everything okay? Are your bowels okay? It's embarrassing to talk about. And on the whole, women will say, oh, it's fine. You know, are you in control? Are you doing exercises? Are you making sure you're strengthening your pelvic floor? Because even women who have elective cesareans, planned cesareans, just carrying a pregnancy to term, it can have significant adverse effects on pelvic floor strength. And you need to be asking the question then, because if they're really young and fit and healthy, they can do so much to try and improve things for years to come. But even then, I recognise women who are really struggling, who've had severe pelvic floor damage from traumatic childbirth, that then needs input, but they're too frightened to mention it. So it should be a core part of the standard postnatal check, is what's going on with your pelvic floor and your bladder and bowel control. But, you know, I think our generation particularly are quite vocal about it, and on the whole are pretty good, but we still need to ask it. There's going to be women over the decades who won't mention it. It's too embarrassing. I don't want to talk about the fact that I leak when I cough and I leak when I sneeze, and I have to wear pads even though I'm 25 and just had my first baby. So yeah, definitely asked about it.
Yeah, it's really sad to think that's to be accepted. And, you know, the chances are it's so much more common than we realize. Like, rarely are you going to be the person that's had the one unusual symptom that no one else has had, because actually probably most people to some degree are experiencing it. So there really is no need to suffer in silence, because, you know, you are professionally trained people. If we can't ask you, you're going to get yourself stuck. So it's just really important to, I guess, practice speaking out, finding someone that you can open up to.
I think a lot of women now are getting quite a lot of help from postnatal groups, and I mean, it's less so since we've been in this pandemic, because that face-to-face interaction has maybe depleted somewhat. But I know personally, when I had my two daughters, I was enrolled in sort of childbirth classes and postnatal groups, and met a lovely group of women. And I mean, I shared all sorts of things that I probably wouldn't have even shared with my husband at those sessions where you're sort of jogging a baby up and down, trying to get them to settle while trying to eat a piece of cake and drink a cup of tea at the same time. But that shared experience of, do you get this? Is this normal? Oh, no, I get that as well. Oh, I get it too. And, oh, maybe I should go, oh, well, I spoke to my GP and I'm doing this, and this. Oh, well, I'm going to go and speak to my GP and get help. Well, I'm going to mention it to the health visitor or the midwife and see if I can get some help. And it just sort of cascades from there, doesn't it? That you've got, I'm not alone in this. There is someone else that can help me. And this is not just for me. There's other people suffering. So, anything like that, just ask for help, really, because it's embarrassing often, isn't it, to start the conversation with somebody, and particularly if you've never met them before. But hopefully you'll get the right outcome on the whole.
Yeah, absolutely. Strength in numbers for sure. And this is a question I like to ask everybody. It's a big one, so it can be a personal or a purely professional answer. But what inspires you?
Oh, there's so many things. I think the thing that's inspired me the most, are you talking about in life or just on a day-to-day basis? Anything?
Anything you like.
So my mother died very early, in her early 60s, from breast cancer, and bless her, she never saw me qualify as a GP, get married. She never met her grandchildren. And I always remember her saying, because I'm the only medic in the family, if you can make someone's life better from something you advise or recommend, then you're going to be a good doctor. And I think knowing that sits at the back of my mind. And I think every consultation I go into, if at the end of that consultation, even if I haven't fixed the problem, but I've listened to that person and that they feel they've had my time and my expertise and that they feel they're cared about, I'm probably doing a good job most of the time. So that kind of, my mum probably inspired me the most to get where I am. I've got a fantastic partner and family that really helped me on that even more. And seeing over the years other specialists and people who've really driven the women's health field and given me the sort of encouragement to do what I want to do has been influential as well. But I think probably my mum was the real factor behind that.
Oh, so lovely. And that's one of the most powerful things you could possibly have to drive you forward. And actually saying that, something that interests me is, how important do you think communication is when it comes to your job? And do you think the relationship between a patient and a GP really does come down to be able to build that relationship and to be able to communicate with one another?
God, I mean, it's the top priority really for a GP to have as in their skill set is good communication skills. It doesn't matter if you don't always know the medicine, because you can say to somebody, this is an area I don't feel completely confident about. I think I know what's going on, but I'm going to ask a specialist for help. But if you communicate that lack of understanding with the patient and say, I'm going to go and ask someone who knows a lot about this because I don't, they'll completely appreciate your honesty. But if you try and say to that patient that you know what's going on when you don't really, the whole thing falls apart. And the reason patients complain and the reason patients get frustrated is predominantly poor communication. They haven't been told what's going on. They don't see the full picture. And there's just a misunderstanding about what's going on. If you're blatantly honest and say, this is why I'm advising this is the rationale, this is what I think's going on, or I don't know and I'm going to go and find out and then I'll get back to you. It's so much better. And when you see communication done really, really well from your colleagues, or you're doing it yourself, or you see a hospital specialist communicating well, you just think actually you're providing fantastic care for that patient, because they're completely on board with what's going on and they feel that they can then help themselves. Whereas if they have no idea why you've given said pill, potion, whatever advice, they're not going to engage with you. They're not going to take responsibility, and they're just going to get frustrated and feel that you're not doing your job properly. So it's the most important thing skill-wise to have as a GP. And when I do teaching sessions, I constantly say to these trainees, it doesn't matter if you don't know the Krebs cycle inside out and the pathology behind pancreatic disease. If you can take a history from a patient and communicate what you think might be going on and make a stab at where you think we should go with this management plan, you're going to be halfway there. But be nice to the patient, listen to them, understand their concerns, and then try and address them. And that's all we need to do in general practice. It's really, really important. And there are lots of people out there who aren't getting that because of various reasons: time pressures, difficulty accessing their GP, miscommunication, And particularly with the COVID crisis is that lack of face-to-face contact, which we all crave because it's what makes our job so much more enjoyable. But things like this, I consult on the video with a lot of patients, and it's lovely when their children are running around in the background waving, "Hello, doctor," and you say, "Okay, great, yes, lovely to see you. Haven't seen you for ages." So yeah, communication, very key.
I love that. And something else I always like to get everyone to leave us with. I'd like to give you the floor to share one thing you think everyone would benefit from knowing.
The one thing. Oh gosh, there's so many, Vicky. I don't know which one to pick.
It can be an extended paragraph, it's fine.
Okay, so the thing that I think everybody should know is that for the majority of women, HRT is fantastic and works amazingly well, and that there's not many circumstances when you cannot have HRT, and for the majority of women, it will revolutionize your life. So don't be scared to try it. If you try it for a few months and you don't like it, no harm done. You're not going to get breast cancer tomorrow. It's perfectly safe to have a go. But actually, don't suffer in silence, because there's so many fantastic options out there that can make your life significantly better.
Thank you. That was fantastic. And if any of my audience would like to get in touch with you or follow you, where can they find you? And I'll pop it all in the show notes.
So I have a website, which is oxfordmenopause.com, which is my private website. I am also on Facebook as Oxford Menopause and Instagram as Oxford_menopause. So you can follow me on there. I'm also on LinkedIn as Dr. Katie Barber. So we'll accept people on LinkedIn as followers as well. I'm just quite new to the social media and putting myself out there. My husband is my kind of IT comms guru. So he's taught me everything I know about Instagram and Facebook and all of this. So I'm getting on with it slowly. And I've got some colleagues who are quite good at communicating on the whole social media platform. But anything on those resources, yeah, you should be able to find me. And I have a blog and I put posts up about various topical issues about menopause.
That's fantastic. I will pop links to all of those places on the show notes so people can just click right through.
Perfect.
Thank you so much for your time today. I know everyone's going to love this conversation, so thank you.
Great. Thanks, Vicky.
Thank you so much for listening to episode 33 of the LiveFitNow podcast. I really hope you enjoyed that conversation as much as I did. I know it's the first time I've returned to a specific subject, but I think it's so important and there is so much to take home from this subject area. I hope you are able to share this with your family and friends, whether that be via word of mouth, social media, send them over a link. But I think we all need to understand this more, men and women, because the more knowledge we have, the more empowered we are. So thank you again. I would love to hear from you. Don't forget you can email me directly, hello@livefitnow.co.uk, or follow us on any of our social medias by clicking through the show notes. Until next Thursday,